Good morning, all. I'll be making a presentation on palliative care in neurological disorders. Myself, Dr. Sinu. The co-author of the presentation is Mr. Tirayvalli, Department of Psychiatric Social Work, NIMANS, Bangalore. Worldwide, only 2 countries have well integrated palliative care into their healthcare system. Palliative care services at hospitals for neurological conditions in Western countries and in developing countries are very limited, especially in India. Neurological disorders are recognized as most leading cause of death and disability. It is the second leading cause of death worldwide, 9 million per year. More burden is in low and middle income countries. There is a 39% increase in death by neurological disorders. 276 million people have died due to neurological disorders, and 15% increase in dying. Tetanus, meningitis, and encephalitis have only neurological disorder have shown decrease in death rate, according to Global Burden of Disease 2016. The common neurological conditions such as dementia, motor neuron diseases, subacute sclerosing panencephalitis, muscular dystrophy, and Parkinson's diseases need immense palliative care. The importance of early identification of palliative care need in neurological conditions will be highlighted in this presentation. Case study approach was used in this study to have a deeper understanding about the integrated palliative care services in neurological disorders. Now, as I mentioned earlier, what are the conditions which will be requiring palliative care in neurological disorder, such as Parkinson's disease, dementia, stroke, SSPE, mitochondrial disease, demyelinating disorders, neurocognitive disorders, Duchenne or muscular dystrophy, requires palliative care. From the time of diagnosis, once the diagnosis is made, we can start the palliative care. Now, what are the indicators of palliative care in neurological disorders? When they are dependent on activities of daily living, advanced stage of illness, burden among the caregiver, bedridden, their food intake is less, urinary incontinence, chronic nature of the illness, cognitive decline in patient, deteriorating condition, disabling condition, degenerative conditions, progressive nature of illness, incurable nature of illness, life-limiting disorders, loss of functions, poor prognosis, muscle mass decline, 10%, non-responsive to active treatment, rapid progression, speech problem, increased difficulty in communicating their needs, swallowing difficulty. Treatments are no longer benefiting the patients, uncertainty about the recovery, uncertainty of living, weight loss in the last 6 months. These are only certain conditions we identified indicators for palliative care in neurological disorders. Like if any one of the conditions fulfills, then patient requires palliative care. Now, most of the neurological disorders nature are abrupt in onset, burden to the family members. Cure is not available in many neurological conditions. Chronicity nature, disabling, fatal in certain conditions. Most of the neurological disorders progressive, unfavorable prognosis. Now, as I mentioned earlier, most of the disorders are incurable, which does not mean there is no intervention. Here, what are the intervention can be provided? Ranges from treating the symptom reduction, symptom relief, arresting an attack, slowing the disease progression, sometimes complete cure of the illness, circumventing the functional disability, providing support to the patient and family. Now, most of the onset of neurological disorders are sudden. Sometimes it could be fatal if untreated, like stroke. Recovery process is insidious. Most neurological disorders are treatable. Many of the survivors are left with serious neurological disability after the incidence of illness. Now here, so how we can apply palliative care in neurological disorders? Whatever may be the disease, however advanced it is, whatever the treatment have already been given, there is always something which can be done to improve the quality of the life of the remaining to the patient. Many of us will know what the palliative care is. So we will be focusing on symptom relief and improving the quality of life. Right. So what are the goals? Mainly to improve the quality of life. Right. So I will be telling my case vignette, like what are the conditions we have seen. A 6 years male child was diagnosed with DMD, Duchenne muscular dystrophy. The child was referred to psychiatric social work team to disclose the diagnosis and to communicate the prognosis. The child is having moderate disability. Now here in this case, the child's mother also having physical disability due to poliomyelitis, and she is feeling guilty that because of her disability, the child got the illness. She lacked the awareness and knowledge about DMT. So the child asked, "What happened to me? Why I am not able to run like my sister?" And the father also asked how long my child will live. Mainly, most of the children with DMT disorder, their life is limit. The maximum they can live 2 to 3 years. So that is their lifespan. Once it was diagnosed, sometimes it may little more. No, they might survive. So, but that the child may not live for a longer period. Coming to another case, Vignet, a 15 years old female was diagnosed with SSPE, subacute sclerosing span encephalitis, had an onset of symptoms 2 years before. She dropped out of school due to illness. The treatment kept for 1 year because they thought magical religious treatment would benefit them. In India, it is a common practice when people do not know about the diagnosis, they take them to a traditional healer, magical religious practices. The patient was brought to our hospital in March 2020. The child was referred to psychiatrist social for breaking the bad news. So if you like the parents were asking if you take her abroad, will there be any improvement in the symptoms or definitive treatment? All we expect is to be independent in activities of daily living and go back to school. We have a belief that she will walk one day for sure. No, this is even more dangerous. Subacute, SSP disorder, the death will be soon. Earlier, the children will die. Now, case Vignet 3. A 61 years old male, married, illiterate, belongs to lower socioeconomic status from a rural domicile, had his first visit to tertiary care hospital in February 2020. Presented with the complaints of memory disturbances, wandering behavior, apathy, difficulty in daily activity for the past 1 year. And the symptoms worsened in the last 6 months. The patient was diagnosed with frontal lobe dementia. These are the Addenbrooke score was 39. Cognitive examination revealed moderate impairment. This patient was referred to a psychiatrist social worker for addressing the caregiver burden. The caregiver was having more burden and to educate about the illness. We did the psychosocial assessment. It revealed that the family has a poor social support system. The patient wife, she is also aged, the sole breadwinner of the family and primary caregiver. And there was extreme burnout with the difficulty. She is unable to handle the wandering behavior, patient's wandering behavior, and she used to assist in activities of daily living. Now, what she expects from the treatment team is complete cure from the illness, and she wants patient to be independent in activities of daily living, which she is unable to manage her assisting in independence of daily living. She told, "We both are alone. Please admit the patient here and offer a job for me in the hospital itself, as I'm unable to handle alone. Being in the hospital makes me feel better than taking him back to the home, where no much support is available." Another case, Vignet, a 38 years old female from rural background, diagnosed with young onset of Parkinson disease, ADL dependent, referred to psychiatric social work team to break the bad news. And her illness condition is not improving and symptoms are worsening. So she was admitted for the second time in our hospital. We did an assessment. The assessment of psychosocial issues revealed there was a family history of Parkinson disease in elder sister, and she passed away. And she is a mother of 2 children. Her family is in the stage of school-going children, and her parents were living 150 kilometers away from her home. So once in 3 months, she will be in her parents' house, mainly due to caregiving. So the primary caregiver was the grandmother. So patient was married to a maternal uncle. That is how the grandmother was taking care of the patient. Husband stopped going to work to take care of his spouse. And they also expressed there was a financial constraint and not willing for institutional based palliative care for which they need to pay. So her expected life years 1 to 2 years she might survive live. So that was the told by the treating team. Then based on that we started providing the palliative care. So what we thought, as they cannot afford to institutional palliative care, so we have suggested home based palliative care. So we assess the patient and family needs, address the caregiver burden, and communicated the prognosis to the husband, identify the surrogate decision maker for advanced care planning. Patient spouse was supportive to her, and she has he has not given up her, and the patient has become bedridden, less communicative. They want to keep her at home and wants her to be with them till her death. So end of life care issue will be briefly discussed. In most of the studies, what you have seen in the literature, many people die at hospital. People who need palliative care. What is their wish be? They wanted to be at home with the family members. They want to die at their home place only. So this is the literature we have seen in many of the patients who are in the end of life care issues. So here the husband said, though we can understand the illness, it is hard to accept the fact 3 years ago we lost a sister. We could see her almost reaching that stage. We could not afford to keep her in our nearby hospital, which is very expensive. That is why we have brought her here. This place is familiar to her as well as to us, so that she feels comfortable in continuing the treatment and we temporarily feel relieved from this pain. So now in routine hospital in a tertiary care, we can integrate the palliative care. Now in the earlier palliative care, what happens? I think this we have taken it from the Journal of Palliative Medicine, Tamil 2010. This model is very suitable. An olden model, when the diagnosis is made, there is no opportunity for palliative care. At the end only, but no, on the end stage, the palliative care is provided in hospice care. But here in the new integrative model, once the diagnosis is made, right now we can start palliative care, multidisciplinary interventions. Then bereavement, we can address all those issues. So what are the tools can be used in neurological disorders? Palliative performance scale, palliative outcome scale, Edmonton symptom assessment scale, support, and palliative care indicator tools. What are the barriers in providing palliative care neurological setting? Now, as we have limited bed availability, though our hospital is 1,000-bed hospital, 500-bed hospital goes to psychiatry, and we have 250 to 300-bed availability for neurological disorders. In India, most of the neurological conditions do not have insurance coverage. So now recently, the government of India has come up with universal health coverage, which gives 30,000 per admission. Maximum 5 lakh they can get during their thing. So most of the disorders, private companies do not provide insurance, and the clinician awareness about the palliative care neurological disorders is limited, and there are very less trained people all over India. Not many professionals are trained in the palliative care, and there is no palliative care policy. So most people think the palliative care means cancer. It is associated with cancer or HIV, life-limiting terminal illness. This can be applied to any chronic illness, any disability conditions, right? So conclusion, palliative care services in neurology are at infant stage in India. There is a limited awareness about palliative care for chronic neurological disorders among the social work trainees, neurology trainees, and other healthcare providers. Persons with chronic neurological disorders often have limited access to palliative care. So there is a strong felt need to increase the awareness and the access to palliative care for persons with chronic neurological disorders. Social workers could play a vital role in providing palliative care for chronic neurological conditions. So each trainee is posted that can be started with a training in neurological disorders for providing palliative care. Thank you so much for all of you for patient listening.